Well, welcome everyone to Psychopharmacology. We are here with our very esteemed Dr. George Kapalka. He has um, graciously allowed us his time to talk a little bit more about his experiences and his training in psychopharmacology. But let me go ahead and dive into this bio just a little bit. It's really impressive. So, Dr. Kapalka holds a PhD in clinical psychology and a master's in clinical psychopharmacology. He's board certified in clinical psychology and is a fellow of the American Psychological Association's divisions 53 and 55. Over 20 years, he's led private mental health clinic in New Jersey that primarily focuses on the assessment and treatment of children and adolescents with learning and emotional problems. He's a certified school psychologist, and he's led state-listed independent child study team that provided assessment and consultation services for various school districts. Trained in psychopharmacology since the early 2000s, Dr. Kapalka has frequently consulted with pediatricians about the use of medication in the treatment of children and adolescents, which Dr. Kapalka is one of the things we just recently talked about in the class, some of the challenges, and specifically looked at a documentary that came out in 2008, and then the follow-up called The Medicated Child. And so very interested in a little bit about what you have to say around pediatrics and medication management as well. Since moving to New Mexico and becoming a prescribing psychologist, Dr. Kapalka is based at CTC Mental Health Services in Albuquerque. In addition to all of the clinical work, he has taught for a year or two or 30 graduate students and developed master's programs in New York and New Jersey. And he is currently the program director and department chair and distinguished professor at Alliant International University's California School of Professional Psychology in our MS in Clinical Psychopharmacology program. He has authored and edited 6 books and many other forms of publications, and his book, Parenting Your Out of Control Child, has been translated into 10 different languages. His research continues to focus on the psychological, pharmacological, and combined treatments of pediatric disorders. And we are incredibly thrilled to have you and all your wisdom with us this evening. So thank you, Dr. Kapalka. And so I guess what I'd like to do is just kind of start off with asking a little bit more about what inspired your interest in training in psychopharmacology.
Thank you. I enjoy speaking about this topic because it's a relatively new direction for psychologists to go into psychopharmacology, something that I became interested in just about 30 years ago in the 1990s. I had always had an interest in child and adolescent psychology, clinical work with kids, teens, and families. And my background in medications was not very strong when I was originally getting my training. Didn't have really very much exposure to it at all. But as I became a psychologist, I started to work more and more with kids and teenagers who were on medications. So I started to have more interests about that. Took some continuing education courses in the 90s to learn a little bit more about it. And then the prescriptive movement for psychologists really started in the 1980s
Mm.
with the first state trying it at the time, which was Hawaii. It failed, but it started to wake up this interest among psychologists, saying that, if we get some additional training in medicine and psychopharmacology specifically, adding it to our existing training as psychodiagnosticians and psychotherapists, and our knowledge of psychological theories and approaches and developmental theories and all that, adding it to some medical knowledge would prepare as well to have all the tools kind of in our toolbox where we can intervene when necessary. We can do an in-depth psychological assessment to clarify diagnosis and treatment needs. But then when we intervene For those cases where it's appropriate, psychotherapy, family therapy, various modalities. But for those cases where, in addition, some medications can be helpful, we could do that, right? So there was actually a group of about what grew to about 300 psychologists across the country that were interested in it and started to complete some of the early training that was being formed around the country at that time, and it was really part of that whole movement that actually Alliant started its MSCP. Most people don't know that actually the Master of Science in Clinical Psychopharmacology at Alliant, CSPP back then, because there was no Alliant yet. So the one at CSPP actually was the first in the country.
Ah,
And
look
that
at that.
really started the entire movement. And actually, the first couple of classes of students that graduated with that degree went on to become prescribing psychologists in Louisiana, which is
Wow.
what the program was originally formed to do. And then, of course, we had New Mexico and Louisiana as the first two states. Now we have 7 states that allow prescriptive authority. So it was really since that time that I had a lot of interest in psychopharmacology. I had practiced in New Jersey until about 2017, which is when I moved to New Mexico. So I had completed the training and I did a lot of consultation with prescribers, with pediatricians on medication needs for kids while I was in New Jersey. I was not prescribing at the time, but then when I moved here in 2017, I became a prescribing psychologist.
That is so fascinating. So there are 7 states currently that, allow for prescribing psychologists. That's interesting. And Alliant was the first to
I was the first. We were leading the way, yes.
I love that. I love that. So, I can only imagine some of your experience, especially early on in your work. So I'm curious, what are some of the unique aspects that you've experienced in prescribing, specifically for the pediatric population? That just seems to be one that we were really struggling with as a class. All the complexity of prescribing to pediatric.
So, I think pediatric psychopharmacology has a few challenges. The first challenge is the availability of
Mm,
psychotropic medications for that population. So, of course, in the US, we have a large number of psychotropic medications, a lot of different antidepressants. We have medications for ADHD, medications for anxiety. We have antipsychotics, mood stabilizers. We have all these different categories of medications, but actually very few of them, with the exception of ADHD, which is an
mm,
exception to what I'm about to say. But other than that area, there are actually few psychotropics which are specifically FDA approved
mm,
for use in the pediatric population. So the vast majority of medications used in the pediatric population are used what we call off-label. What it means is that the medication was brought to market and approved for psychiatric use for a different population, usually adults.
mm,
And it is legal to prescribe it now to children, but it's really up to the conscience of each prescriber to decide whether or not, in addition to its FDA indication for adults, does that medication, one, have enough research based results to suggest that it might be effective in the pediatric population, and two, that the safety is such
mm.
that now prescribing this medication to children and adolescents instead of adults, would that still continue to be safe, or are we potentially, risking some additional problems and side effects that are not yet reported in the literature? So those are really the main challenges that have to do with the fact that so many medications prescribed to the pediatric population are prescribed off label.
Mm,
And
and
now some of those, even though because you see, a lot of that has to do really with politics and finances.
mhm, mhm,
So a pharmaceutical company really does not have to go for a second indication.
Mm.
Once it already has a medication on the market, now approve it for something else so that it can be, the only benefit for um, pharmacological, for a pharmaceutical company to do that is that the only advertisement that's permitted for a medication is for the FDA approved label.
Um,
So any medication used off label
okay.
cannot be advertised as being used for that purpose. So that
Mm.
really would be the only benefit for a pharmaceutical company to go back to the FDA and say, we have this medication approved for depression in adults. Now we want to have it approved in, let's say, pediatrics ages 9 through 17, right? So on the one hand, yes, perhaps it would open up another potential population for that pharmaceutical company. On the other hand, the costs of getting another FDA indication are so substantial,
Mm.
and the research requirements are relatively onerous in terms of just how
Mm.
much stuff has to be submitted to the FDA to receive that to be honest with you, most companies don't bother.
Mm.
So then we have a drug that's available on the market. Safety and efficacy has been approved for adults. It has been established. But
Mhm.
now we're using it with children and adolescents for a use that is not officially endorsed or
Mm.
approved by the FDA. Now, in some use cases, these medications from the research that has come out after the medication has been on the market. In some cases, there's very extensive research base of some medications, even though they're not approved for kids, really working pretty well for kids and being safe. In other cases, that's speculative. And so each pediatric prescriber has to be aware of the research base to be able to determine whether or not any given medication is safe and effective potentially for use with the pediatric population.
So you had talked about, some of the unique barriers in terms of politics and funding and whatnot. And I am just curious, are you seeing currently with the changes in administration and some of the, especially around research? I'm just curious if you've seen anything trickle down to the pharmaceutical field that you are familiar with.
So, the changes and hopefully some of them will not go through in their intended
Hmm.
version. We've already seen, thankfully, some pushback, for example, when it came to the cuts that were proposed for the National Institutes of Health, right?
Yes.
So thankfully that's still being debated, and hopefully the cuts, if any, will not be nearly as extensive as they proposed. So there's really two prongs to this, probably
Hmm.
more, but two that come to mind immediately. One is the research itself.
Hmm.
And of course, if you stop funding research, you stop new developments.
Hmm.
That's not only relevant to psychotropics, that's even more relevant to diseases which still have relatively few, cures or treatments, right?
Hmm.
Like cancers, some heart diseases, diabetes, some dementias,
Mm.
so a lot of these diseases, there's treatments available for them, but of
Mhm.
course we're far from being able to cure these diseases,
Mm.
right? So the concern is that if research funds start drying up, how much research and development will be able to be done to continue to propel progress that
Yeah.
we all hope to have? And to be honest, America really should be concerned about being competitive with the rest of the world. And if
Mhm.
we start eliminating funding for research in the United States,
Mhm.
researchers and companies, they're going to go elsewhere, right?
Mhm.
China already actually has made a statement that, with the US now not being so welcoming to foreign scholars, that's
We're
fine.
opening our
That's
doors.
good
Yeah,
for
yeah.
us. come on down. We're ready for you, right?
Yeah.
So that is a dynamic that unfortunately in America is not being thought about enough because we might be, losing our competitive edge there. What I'm even more concerned about is that with the current cuts that they're talking about, what is going to be impacted is healthcare,
Ability.
healthcare insurance, healthcare coverage, the availability of treatments of all different sorts
Yeah.
will be diminished, and which portions of the populations are going to be affected first? The poorest and the most needed, the most underserved, the ones that already have the most difficulties with access. So if we now eliminate, so much funding for Medicaid, what's going to occur with all these, people who rely on Medicaid for their health care? This is a significant problem. I'm in New Mexico, and New Mexico is one of the states in the country with the highest proportion of the population being covered by Medicaid. So
Wow.
all of a sudden, and of course, the federal funds have been crucially important to us to be able to continue to do that. So now, if that dries out, what do we do with all these people? And a lot of these people are kids and adolescents, because a lot of Medicaid is assistance to families which need additional support to get health coverage for their children. So a lot of these kids and adolescents are going to go without coverage. This pertains to medications in a number of ways, and some ways that we don't really think about, but I think we should. Um, so we already have a problem that those portions of the population which are underinsured,
Hmm.
meaning they have health coverage, but the availability of treatments is very limited.
Mm.
So when these people have mental health needs, what do they get? Do they get medications or do they get psychotherapy? They
Mm.
get medications
Great
because
journey.
medications are cheaper. And a provider can see them once or twice a year to refill their scripts. They don't need weekly sessions, right? So now we already see that in this country. There's actually trends, and you see that in Medicaid. You see that especially in foster care. Foster
Mm.
care kids are medicated at 5 times the rates of foster care children. The main reason for that is availability of other types of treatments. Okay, so now we're going to even more so push especially the more needy and the more underserved portions of the population to receive nothing but medications, if
Mm.
that, because everything else is going to be pretty much taken off the table. So it's those kinds of factors that really drive some of the trends. And that's one reason why in the US we medicate children many times more so than we do in other countries, like in European countries. Why? Because their healthcare system is such that psychotherapy services are covered with parity for medical treatments and medication treatments. Therefore, they don't need to make this choice given their availability of their healthcare coverage. They don't even have to think about healthcare coverage because so many of these countries have nationalized healthcare. So
Mhm.
that's not even a decision they have to make, right? They just know that as availability of treatments, that's one of the treatments they can choose. And many families having that kind of a choice for their kids and adolescents, they do choose psychotherapy. In the United States, that's an additional obstacle which drives the prescription rates for psychotropic medications for the pediatric population.
Wow. So that's a very interesting angle that I know I hadn't thought about in terms of the impact of some of these cuts and reorganizations with respect to the psychopharmacology. I was thinking accessibility, but now we're also talking about choices.
Right.
Choices.
Absolutely.
What type of treatment? Interesting. These are clinical counselors. that are in this program, and they're part of the role of this course is to educate the students so that they can better serve with medication monitoring and collaboration with the physicians and the prescribing provider. What kind of things would you advise these students? What kind of things have you seen that it's helpful, not helpful? We really, I would appreciate any tips you have for them.
So let's start with the first point of contact with the prescriber, which would be at the point of a referral, right? One thing that non-prescribing mental health professionals, I think, need to think about and appreciate is that the medications we have available, these medications are meant to treat specific symptoms. We really don't have medications that are meant to treat disorder entities.
Mhm.
We have medications that treat specific symptoms that may be part of a given disorder. So, one thing that is often less helpful to a prescriber to hear is all the dynamic reasons why a therapist feels that a person is having a problem. Family dynamics, history of trauma, conflicts with the spouse, problems getting along with their peers, difficulties with schoolwork. Those things are important to some degree, but you have to understand that it is those kind of factors don't drive medication decisions. What drives a medication decision really is the symptoms. And being that I'm a psychologist before I became a prescriber, I actually enjoy having these kind of conversations with therapists because they're speaking my language, right? But something I got very used to when I was working as a psychologist and consulting a lot with medical prescribers, especially pediatricians, they want a brief conversation that succinctly explains why you are referring someone for medications, and that why really has to do with what symptoms do you think are the most important and the most impairing
Mm,
to the person at this time, so that to treat those symptoms, we can consider a medication. So if we can really cut to the chase and just summarize the most salient points about how the person is functioning and what actual functional difficulties and symptoms they're experiencing now, that probably is the most important for a prescriber to hear. So now let's say you are collaboratively with the prescriber treating a case, the prescriber is seeing them. I usually see patients once a month, but I know a lot of psychiatrists and other professionals see patients less frequently, maybe a couple of times a year, right? But even with me seeing patients once a month, it's still less frequently than a therapist who usually sees them, weekly, maybe once every other week. When we have contact in the course of the treatment to kind of update each other on how things are going, what the prescribers look for from therapists is A, keep in mind what I said before. When I prescribe this medication to treat those particular symptoms, how are those symptoms doing? I'm not really interested in how well their family dynamics are resolving, right? I'm not really interested on how well the person is getting along with their spouse. I may be only to the extent to which that may describe some of their symptoms, right? But again, keep in mind that medications are really very concrete in what they're trying to do.
mm,
So the first thing we need to hear is I prescribe this medication to treat a few concrete symptoms. Have these symptoms changed? The second thing I really am interested in hearing is now that I'm prescribing a medication, and of course, every medication does not only what we want it to do, but it also goes through every single compartment in the body, right? So it
mm,
may have effects on other parts of the body.
mm,
So the other thing I want to do is, are there any side effects? Are there any changes in energy, in libido? right? In ability to pay attention, in sleep, right? In appetite, in weight. Are there any changes in those kinds of things? And I think counselors and mental health professionals who see patients on a weekly basis really are in the catbird seat to
Mm.
be able to collect this kind of information because you're seeing patients so frequently. So as a prescriber who may have a contact with a therapist a couple of times a year, maybe to just kind of get updated, that kind of information is really helpful to me. Is have you seen changes in life patterns that have to do with, with weight, with appetite, with sleep? Are you seeing things that could potentially be attributed to be side effects of the medications?
So I am curious, what advice do you have for clinical counselors who are working with client and they're using all of their superpowers in mental health tools and they're like, gosh, I really think that a consultation for a medication would be so supportive for you or your child or your, loved one, and there's so much resistance against it. What are some of the tips that you might have for these counselors?
One thing that I even try to communicate to some of my patients, and certainly the mental health professionals I interact with, and this becomes especially important when you work with kids and adolescents, especially teens, right?
Oh, yeah.
So I always like to kind of say somewhere early during the process of my interaction with them is that just because you're speaking with me does not mean you will leave my office with a prescription.
Mm, mhm,
You may, if we agree that something might be helpful to treat, if I explain the options to you and you agree that perhaps trying a medication might be a good way to address this, then of course I'll be happy to write that for you. But the main purpose of me seeing you is to see how you're doing and review options with you.
mm,
So then you can have a better idea what your options are. Now, you may decide that one of my options I'm recommending is right for you and you want to try it. You may want to think about it, right? So that's what I would advise therapists to try to kind of encourage their clients to see is that when you refer someone for a consultation about a medication, that's exactly what it is. It's a consultation. Feedback of which may be that something is recommended, but even if it is, it doesn't necessarily mean that it has to happen, that you actually have to take. Helping clients realize that they're in the driver's seat in the end.
mm.
That really it is them who will make that decision if they feel is right for them, right? So a consultation is simply to review some options. That may help with some of the resistance.
I love it. You had mentioned some of the types of resistance. I know in my own clinical practice, it has been anywhere from I don't want my libido to be impacted, I don't want to gain weight, and I tend to, sit and say, gosh, well, let's kind of look at this. Let's look at how can we be proactive around maybe some of the possible side effects. But what are some of the, tips that you might give clinical counselors if they're working with a client who maybe is resistant to a consultation for those reasons, or they're finding they are having some side effects and they're contemplating stopping medication for those reasons?
So let's take the second example first, because
Okay.
to me that's a situation that more urgently needs to be attended to, right? Because it may impact the efficacy of the treatment that they are receiving.
Mhm.
So I always want patients to feel their that my door is open for them to express concerns. And I also want patients to appreciate that nowadays we have such a wide variety of medications for most indications. There's still a few areas where there's maybe not quite as many, but really for most of the typical types of symptoms that might be treated with medications, anxiety, even manic symptoms, psychosis, ADHD symptoms. We really have a pretty wide choice of medications. And for these various medications, the side effect profiles vary. They're not all the same. They are antidepressants which affect libido.
Mhm.
And to be perfectly honest with you, the kind of effect that they have in libido for some people is a problem, but for some people is actually an improvement.
Oh, there you go.
So one shouldn't always think of it as always being, in the same box. But even I'll be happy to tell you what I'm talking about if you want to get back to it shortly. But just to finish my point, there are medications that do affect libido, and there are other antidepressants which do not in any way affect libido,
Mm.
have no effect on it whatsoever. There are a few medications that may affect weight by increasing a person's appetite and maybe affecting their metabolism. There are actually a lot of medications that don't. Most antidepressants, in fact, do not have weight gain associated with them. There are a few that do, right? But for someone who is very thin and not eating very well, sometimes that's actually a benefit, right? But then if you have someone who is struggling with their weight already, well, then any good prescriber would not put them on a medication that potentially can make them even more,
Mm.
right? So I guess the main point here is that not all medications have the same side effects.
Mm.
And we have so many choices of medications now that we can tailor the fit between the medication and the patient in such a way that the patient tolerates medication.
I have one more question, and then I want to open it up to the students who are here. Have any questions? But we have seen a huge transition in the way we offer our services as providers. Especially post during COVID, during the pandemic, we started seeing more telehealth. I know for me as a mental health professional, my practice went from brick and mortar to exclusively online, and my clients became very comfortable with that. So I am still doing telehealth. And I'm curious how that has impacted psychopharmacology with telehealth.
It's impacted most of healthcare. It's impacted a lot of medical types of services, and medication management, of course, is a medical service.
Mhm.
So it has impacted it. Certainly at this point, we do far more telehealth than we did prior to
Mhm.
to COVID. And there are both national guidelines for that, as well as I think every provider has to kind of develop their own comfort zone in terms of what they're comfortable handling via telehealth versus in-person visits. In the clinic where I work, probably about half of the patients that we see are physically located near enough to our clinic
Mm.
that even though they may prefer telehealth and we may do telehealth with them routinely, we can ask them to come in for an in-person appointment if needed.
Mm.
So we would do that when a patient maybe required a medication adjustment, and the medication is such that maybe higher dose could potentially affect maybe their blood pressure or
Ah,
their weight, or so then we would ask a patient like this to then come in for an in-person appointment the next time, so we can actually do a physical examination and assess the impact of the medication on the person in person. For some medications, even if patients are stable or showing no side effects whatsoever, my rule is that I need to see patients at least once a year in person,
mm, mhm.
and I will do my routine check with them. And especially since I work so much with kids and adolescents. I'll take their height and their weight. I'll see how well they're developing, how well they're progressing. I want to make sure I always compare their height and weight to appropriate charts to see whether or not the patterns are changing in terms of their, how they're growing. I always take their blood pressure and pulse, and that's a really important aspect to check regularly with the pediatric population because unlike for adults, when you pretty much have one standard that applies to most adults and maybe is altered a little bit as the person gets older, for kids and adolescents, the systolic, diastolic blood pressure ranges and the pulse ranges vary widely by age group.
Mm.
So I have charts and tables that I use routinely for every one of my pediatric patients to make sure that whatever medication I'm prescribing for them has not changed their blood pressure or pulse in any way that is now not within the range that is expected to be normal, for their developmental level. So I definitely want to, check things like that. For the half of patients that we have at the agency that are not physically located close enough for them to come for an in-person session, then we require them to either have a primary healthcare professional, pediatrician, or a PCP that they work with. So we will require them to have an at least annual visit with them during which their physical health is assessed, and then we require a copy of that assessment so that we know how they're doing. And for some patients that have a little more complex psychopharmacological profile, we actually, in most areas of the state, even though they may not be close to us, they may be close enough to see another mental health prescribing professional, not on a regular basis because they may not have room in their caseload to accept them as a regular patient, but for a once-a-year check, they will see them, right? And then they can, again, provide that information to us to make sure that they are doing okay. So there's really no one that we see that is exclusively telehealth,
Mm-hmm.
for years without seeing a patient. At the minimum, we would have annual contact with the patients.
Yeah, that's what I would imagine. I would imagine in terms of just it sounds like a good standard of care to be able to have that full physical and to kind of have an eyeball on your patient.
And
Yeah.
that's about to become a national guideline because even though
Oh.
it's been delayed in approving it because of access issues that have resulted in the implementation of this rule, being delayed as people, providers, and in areas of the country, you know, become better able to have at least some providers for people to be able to seek that. But there will be a time, probably in not too distant future, when that will be passed as a regulation.
Mm.
That patients will need to be seen at least annually, for all psychotropic medications that are handled or prescribed through telehealth. This is specifically being argued now for controlled substances,
Mm.
but most likely will be applied for all psychotropic medications.
And that makes perfect sense. Well, Raquel and Malachi have joined us from the class, and I am just curious if you have any questions or thoughts or curiosities for Dr. Kapalka.
What is the path like from someone that's in a master's program to becoming a prescriber that's not an MD or a psychiatric nurse? For folks that are in California, I'm sure it's different than New Mexico, but can you say anything in general about that progression to becoming a prescriber?
It's not yet standardized across the country. As I mentioned before, it is only permitted now in 7 states, and California, unfortunately, is not one of the 7 yet. The requirements are such that to become a prescribing psychologist, first you have to become a licensed psychologist. So you have to have a doctorate in psychology, you have to have an internship, you have to, pass the licensing examinations, whatever the requirements are to become a psychologist in the first place, right? Once you become a psychologist, then you can complete the training after you've become a psychologist, or actually now you can complete the psychopharmacology training while you're finishing your doctorate. But whether you completed it afterwards or at the same time while you were getting your doctorate, after you are a psychologist, then you have to pass another separate licensing examination for psychopharmacology. And then every state has essentially an equivalent of a residency in a medical setting that has to be done. So the length of it and who the specific supervisors can be vary state to state. But the way to think about it is it's about probably close to another year of now an experience in a medical setting where you're exposed to medications and you weigh in on medication decisions, even though you're not prescribing yet, but you're kind of doing it under supervision. And that's sort of another internship. Just like psychologists have to do an internship before they become a psychologist, this is another form of like an internship or a residency that's now specifically psychopharmacology oriented, that states require before you can get your prescribing license. And then for most states, you get your conditional prescribing license. Now you can prescribe, but you still have to have a supervisor with whom you're reviewing cases, and that person is ultimately responsible, for what you do. And then after what usually is 2-year conditional period, then your work is once again reviewed. The supervisor has to release you as being ready for independent practice, and that's when you would become an independently practicing prescribing psychologist.
Thank you for that. Yeah, that's really helpful. The other question I had was, I'm interested in psychedelic medicine, how that's taking hold in this country. I know it's very limiting, or there's still limited research, and there needs to be more. But I know that research universities like Johns Hopkins, they have a psychedelic research lab, and they're able to treat volunteer patients with this medication. And I'm just wondering about, whether that'll ever become more than something specific to a few big colleges and universities.
This area has generated a lot of interest with some steps forward and a few setbacks. Some of the psychedelic medications are not on FDA Schedule 1, which means that even though they're not FDA approved for use as psychotropic, they can be used as psychotropic. A good example is ketamine. There's a version of ketamine that is approved specifically for very specific circumstances for where it can be used for depression. Other forms of ketamine can be used, even though there's some regulations around them, but they're legal, to be used for depression, and in fact are being used, by some prescribers. With the psychedelics, a major obstacle has to do with the fact that so many psychedelics are currently on Schedule 1 of the FDA, which means no medicinal approved use, for any purpose, and presumably sufficient danger to restrict its use for any purpose at this time. So for those kind of substances, the research centers have to apply for a waiver from the FDA to be able to do research with those substances. So this is why right now a lot of that use is limited to these big centers, because they need waivers, to be able to do that. We've had some developments with marijuana, right? So if these substances even if they do not become yet approved as psychopharmacological treatment for these conditions, if they're removed from Schedule 1, then that will eliminate a lot of the limitations. As long as they're on Schedule 1, those obstacles will remain. Unfortunately, there's not much that can be done about that.
Raquel, do you have any questions or thoughts or?
I was curious to hear your thoughts on like any upcoming trends, like changes in the space, that you think are good to keep an eye on.
You mean in psychotropic medications or any area of psychotropic medications, or?
I guess psychotropic medications in general, but I'm also interested in like kind of alternative sides too, like potentially like ketamine treatments, but also like TMS is another one that I'm pretty familiar with, but just like in general within the space.
So, it's interesting because TMS is a growing area. Its use for depression is relatively well established now. There have been other uses investigated to things like Tourette's, even for ADHD. There are devices now that are available to actually improve a person's sleep, which is kind of a version of TMS. So there are continued, developments with that. With psychotropics, I have to tell you one thing. It is incredibly expensive in the US to bring a medication to market. It's currently estimated that it's between $1 and $2 billion per drug to bring
Wow.
to bring it to market, right?
Wow.
Rarely less if the drug is really expedited, sometimes even more, right? So pharmaceutical companies, first and foremost, they are businesses, corporations that have to answer to stockholders. While they may have some concerns about how much good they're, whether the potential benefit to society of what they're doing, that's really not their primary concern. Their primary concern is return on their investment and keeping their investors and their stockholders happy, and the company growing in its stock value, right? So with that being the case, when new medications are being developed, pharmaceutical companies always think about, if we invest a certain amount of money into a compound, how big of a market share are we going to have, and just how well is this product going to sell when it let's say it does go all the way and we spend all that money, if FDA approves for us and approves the medications and we can now market it, what are the sales are going to be like, right? And unfortunately, the answer to it is that the sales for psychotropics, by comparison, are really minuscule in terms of the profit they bring to a companies as compared to sales for example, the GLP-1 drugs, right? Now,
Oh, yeah.
So companies have a lot of incentive to bring another GLP-1 drug, especially one that's going to be oral, right? Huge market in that. And the next billion and billion upon billion worth company is going to be the one who does that, rather than brings another psychotropic to the market. So that really stifles, I think, development in psychotropics. And the other thing to kind of think about too is that we actually have less psychotropics in the US than in many European countries. And the reason for that is because the FDA bar is so high, so expensive, and also their safety requirements are pretty high to be for them to approve the medication. So then, as has happened many times, many psychotropics become available for use in other markets before they ever come to the US. So if you're really interested in some of the newer psychotropics that come to the market, and there are a few that are being used elsewhere and not in the US, the first place you're probably going to see them will be somewhere in Europe or in Asia.
Interesting.
Yeah, thank you for that. That is all such good insight. I think it's really important to recognize the positioning of pharma within the global economy. But yeah, I appreciate that. Thank you.
Dr. Kapalka, is it possible that the students might be able to reach out to you if they have questions?
Absolutely. It's George.Kapalka, Kapalka at alliant.edu. And yes, please feel free. My door is always open. I really enjoy interacting with students about these issues. It's a topic I enjoy discussing.
Well, Dr. Kapalka, thank you so very, very much for taking the time. I've learned so much, and you're such a great resource for us at Alliance. Malachi and Raquel, thank you for popping in. Well, hopefully your colleagues will also benefit from the wisdom of our wonderful colleague here.